This interview is another resource provided by the Deep Sea Journey Foundation, and specifically today, it's providing access to care for those affected by breast cancer. My guest is Dr. Kelsey McClure, who practices with a team of other microsurgeons in Phoenix, Arizona at Southwest Breast and Aesthetics. She's a board-certified plastic surgeon and holds certification with the American Board of Plastic Surgery. She's an active member of the American Society of Reconstructive Microsurgery, the American Society of Plastic Surgery, Mountain West Society of Plastic Surgeons, and the Arizona Society of Plastic Surgeons. After completing general surgery training in Phoenix, Dr. McLure went on to complete a plastic surgery training at the University of California in San Francisco. To further her ability to perform complex reconstructive surgery, she then completed a microsurgery fellowship at the Midwest Microsurgical Institute of the University of Kansas. After she completed training, Dr. McLure spent her first 2 years working at the Mayo Clinic, focusing on breast reconstruction before joining the team at Southwest Breast and Aesthetics. Her expertise include autologous reconstruction of the breast, breast reconstruction revision, and cosmetic procedures for facial and body rejuvenation. She has authored several publications. Dr. McClure believes that shared decision-making is necessary to tailor comprehensive aesthetic and a reconstructive plan for her patients. We're going to talk about a topic today that it's often discussed, I would say, in the community that I serve at Deep Sea Journey Foundation, and it is about diastasis. Also recognizing what a hernia or bulge might look like after autologous breast reconstruction, specifically DIEP flaps. So, Dr. McClure, I want to welcome you to the podcast. You and I were supposed to meet at ASRM in Hawaii in January, and that conference is so busy. I'm certain we must have passed each other several times and never got to meet, but it's so good to meet you here finally, and I'm glad we were able to make this connection and get this scheduled. This is a good topic to talk about.
Yeah, I'm glad that we finally met up. It's hard. It's like ASRM becomes a social event. Once you've trained so many places, you just end up meeting more and more people. And then it's just you're like running from thing to thing.
It does, and Hawaii is not a bad place to have a conference, is it?
Definitely not.
Yeah, yeah. Well, okay, I have to give you a little shout out since you did some of your microsurgery training in Kansas, and I'm a Kansas girl. I just have to say Rock Chalk Jayhawk.
Yeah, I really appreciated my last year of training was at KU. KU has a fabulous microsurgery program. So if you're in the Midwest, KU is definitely a center of excellence with about 5 to 7 microsurgeons, many of which do a plethora of breast reconstruction,
Mhm.
and they're all really talented. So I feel lucky to have trained there.
Yeah, I met a new one, and then I saw Dr. Butterworth too at the
Yeah.
yeah. So all right, so let's get to our topic at hand today. Do you want me to pull up the slides now, or do you just want to give us a little background on what diastasis is first, just for the listeners? And I do want to say, we provide these interviews for two purposes, really. One of them is if patients are listening, we want to prepare them for their consult with whatever surgeon they choose to go to. Um, Protocols vary from practice to practice. So, what you're listening to today may not be exactly what's done with the surgeon that you consult with. You may want to, have a second opinion after today's interview. But I also do these interviews for other surgeons to listen to, get some ideas, listen to the process that Dr. McClure is doing. So I wanted to put that in before we begin. So with that. Would you like
Yeah,
me to pull the
I
slides up or do you want to?
let's go ahead and pull the
Okay,
slides up just because
sure.
I think it's a little bit easier to talk while we're looking at a picture.
Okay. And
And then
as
I'll
you,
see if I can actually use if there's a pointer I can use, I'll use it. Otherwise, I'll just kind of try to describe what we're seeing
okay.
here.
And I'll try to do some pointing while you're talking to see if I can hit the right areas.
Okay. So first, we're just going to talk about what a diastasis recti is and sort of what the thought process is about why to repair it during a DIEP flap surgery. So the abdominal wall is made up of a variety of muscles, and those muscles are connected together with a strength layer that covers all of our muscles in our entire body, and that's called fascia. So a diastasis recti is where the rectus abdominis or the six-pack muscle actually starts to separate away. So this picture in B on the image that you're looking at now, this is a diastasis recti that's torn open. So that's not usually the case for someone who's undergoing surgery. This is someone who has an abdominal wall hernia, but you can see this linea alba that they're saying is torn. It ends up being just fascia that's been pulled apart. And that gets pulled apart basically for two different things. Either you're pregnant and the uterus getting bigger inside your abdomen stretches those muscles apart. Sometimes it recoils some, but usually it doesn't come back together all the way. Or you have gained a lot of weight. And that's the other reason that this kind of gets pulled away or attenuated is kind of how we see it.
Mhm.
Um, you can do abdominal wall exercises to help decrease a diastasis. And a diastasis, really, if you're wondering, do I have this? You can lay flat on the floor, lift your head and shoulders off the floor, and just feel midline at the top of your belly. And if you feel a big bulge that's kind of constricted on either side but stays in the midline, that's likely a diastasis recti. Again, more common with larger babies and gaining weight and
Isn't
multiple
it,
pregnancies.
yeah, not to interrupt Dr. McClure, but isn't it when you could kind of press those fingers into a space and feel that space when you're doing that sit up, that mild sit
Usually,
up?
if you try to do that sit up,
Mm-hmm.
yeah, it will either bulge out.
Yeah.
Sometimes when you're laying flat, you can actually feel that there's like a separation of those muscles
Mm-hmm. Yeah.
in a thinner person. Surgically, when we're doing a DIEP, we've lifted the abdominal soft tissue away from the muscles.
Mm-hmm.
Um, and we have to do a dissection that goes all the way up in the midline to the xiphoid process, which is where the ribs come together, in order to be able to close the incision. So we're really looking down at that fascia and those muscles when we're in the OR. And we can use our electrocautery to stimulate the muscle and
Mm,
actually see how wide that diastasis is.
interesting.
So for most surgeons, when they're closing the abdomen after a DIEP, if they note a diastasis, they're going to repair it. And they're going to repair it with sutures at the midline, bringing those two muscles back together.
Mm-hmm.
Um, the thought process about whether we repair it or not is generally guided by BMI. So for some surgeons, when a patient reaches a certain BMI threshold, they don't repair that diastasis because they're worried there's going to be too much tension on that suture repair and it's going to pull apart and it could cause tears in their fascia. So for our practice, generally speaking, we repair any diastasis that we see for a BMI of less than 35 and over 35, we don't generally repair it. There's also some caveats about getting a DIEP flap based on your BMI. And now that we have the GLP agonists, if patients can get down to a BMI of 35, if they don't have an active cancer, they're not needing an immediate DIEP, then it's usually a safer surgery to do at a lower BMI anyway.
Tell us about the GLP just in case some listeners don't know what that
Yeah.
is.
So
It's
now,
it's talked about more and more, but
yeah.
yeah.
So, currently there's a class of medications you've probably heard about, Ozempic and Mounjaro. These are GLP agonists, and they've been profoundly beneficial in helping patients to lose weight that they otherwise have not been able to. So currently in my practice, I would prefer to do a safe, deep surgery. The safest deep surgeries are in patients that have a BMI of 35 or less. Once you get a
Hmm.
BMI higher than that, you have more risk of complications. And so we were always ending up in this conundrum. When a patient was BMI of 40, it's really hard to get down to a 35, right? So how do
Hmm.
we guide them? But we know they're going to have more complications having a deep at a BMI of 40. So currently my recommendations for patients is if we're around that area where we could get you down to 35, I would rather put implants in at the time of mastectomy and let you work with a primary care doctor to safely get your BMI down
Hmm.
and then do your deep when you're a BMI of 35. Then also we're getting rid of that extra belly tissue that you're going to have and extra skin laxity at the time of the deep. And
Hmm.
it's a safer surgery all around.
Hmm.
Some surgeons will still do deeps on patients with a BMI of greater than 35. You just have to know that you're more likely to have a wound healing complication than somebody who has a lower BMI.
Yeah, I'm really glad you explained that, Dr. McClure, because, like they say, if weight loss was easy, we'd all be doing it, right?
Yeah.
And and I think about patients that are in treatment, maybe at an age where weight comes on quicker and it's harder to lose. So I think overall, the goal is to get to a healthy weight, but that's not always easy.
Yeah.
So I'm really glad that you brought that up. Now, is there any contraindication or any stoppage of those medications prior to surgery for any reason?
Yeah, so we always have people hold those GLP agonists for 2 weeks prior to surgery.
Okay.
And that's because there's an increased aspiration risk because it's causing your stomach to slow down in motility. So
Mm-hmm.
that's from an anesthesiologist perspective that they want you to be off of them for a couple weeks before surgery. But really, it's your medicine doctor and the anesthesiologist that are kind of help guiding these things when they want you to be on them, when they want you to be off of them. But I do think that they're proving to be very successful and safe.
Mm-hmm.
They're also getting uh, more uses all the time. So for someone who's right at that cusp, I prefer now that I think it's a little bit easier to, with the help of a GLP agonist, get down the body weight. I'd rather wait and do a deep and just do it in the safest scenario possible. Plus,
Mm-hmm.
oftentimes, if people have a BMI of 40, they want to lose weight. And
Yeah,
then you end up with extra tissue and extra skin that's stretched out that you don't want. And I would love to repurpose that to make breasts, right? If you need it. So it kind of allows
absolutely.
us to take something you don't like and turn it into something that you need.
Well, we're going for the best outcomes we can, right?
Yeah,
Sometimes that takes a
exactly.
little bit of prep to get there. So,
Yeah.
all right. So we talked about the causes of diastasis. So, I think let me quit screen sharing real quick. If I need to pop it back up, please let me know. I
Hmm.
wanted to talk to you specifically about recovery because when I think of diastasis, I know the muscles are running this way, and then there's the separation, but I also think of body habitus. And there's short-waisted people, there's longer-waisted people. Does that come into play at all for recovery when you repair the diastasis? Because I know some patients have talked about after the repair of that, they felt super tight. Are there some
Hmm.
instances where they would feel more than others? Or, and sometimes feeling super tight is a perception.
Yeah. It's not something that we typically really consider. I think that the longer that you've had those muscles pulled away from each other, probably the tighter it's going to feel for a while until you kind of like readjust.
Hmm.
Just because there's more room inside your intra-abdominal cavity when you have that diastasis. So another thing just to mention is that when people have had multiple pregnancies, they have that diastasis, they're more likely to have some urinary incontinence just because they can't generate or hold pressure in their abdomen in the same way.
Hmm.
So oftentimes when that diastasis is repaired, um, they find that they're more continent. So that's
Hmm.
something just a caveat to know. But in terms of body habitus, I don't know that there's, everybody's a little different. Yeah.
True. And I think you made a really good point. You go from this space having that space in the
Hmm.
extra space in your stomach to being tight. And so it is an adjustment at first, to kind of make that switch from the tightness
Yeah.
to, or from the loose, a little bit of laxity to the tighter skin. So when women are recovering from this, do you recommend at all that I'm asking questions about things I've heard in my community. Do
Yeah.
you recommend at all that they use a walker? I've heard some say, they use a walker at the beginning for stability and for that tightness. What are your thoughts on that?
So most people probably don't need a walker.
Mhm.
Um, for some women, especially smaller women that are getting a DIEP, their skin is going to be pulled tighter to close the bottom incision.
Mhm.
So those people are definitely walking a little more hunched over for the first couple of weeks. Our skin and our bodies are designed to be compliant and to change with us. So usually it's like week 1 or 2, you might be walking a little bit hunched over, but by week 3 or so, you're kind of starting to stand up. And we routinely send people to breast physical therapy at week 3. And those people also work with people to get standing up straight again. Um, it's just kind of person dependent, but not, we don't routinely send anyone with a walker. But if someone's like, wow, I'm really having trouble, my low back is hurting,
Mhm.
then you can walk with a walker. But I think it's probably not 100% necessary. It's more of a comfort thing. And I tell
I
people, like, if you stand up too straight and it hurts at first, then just kind of back off. Then you need to be a little bit more leaned over. And by week 3, then you're able to kind of stand up totally straight. And working with a physical therapist is really helpful with that.
I'm really glad you brought that into play to the physical therapy because I think that's important. And I share that with a lot of women, how much good physical therapy can do after this. So, um,
Yeah.
and my personal feeling too, I felt very tight after my own DIEP. I know when I walked, right or wrong, I don't have any evidence to go on this. I'm talking about personal experience. I literally would kind of pull in those side muscles, those
Hmm.
transverse muscles when I walked because I feel like there's this kind of false sense of tightness sometimes right after this surgery, but those
Yeah.
core muscles still need to be worked. So just really gently, I would kind of pull them in when I was walking and do that gradual stand up over time. Um,
Hmm.
that's just what I did personally, and it seemed to be able to get me to that taller position a little bit. So you did bring up something else too, the back pain, which I also hear about. So what do you do when patients come in and they say, I just have a lot of back pain right after surgery? A lot of it is the tightness.
Yeah, some of that's the tightness. Some of it is the bed that you're sitting in or the fact that you're like sleeping in this beach chair type position.
Mhm.
So alternating heat and ice, ibuprofen. Really, you're just trying to get through those first 2 to 3 weeks.
Right.
And then that gets much, much better. And it's like none of us want to be walking around like a little old lady. So that's obviously going to make your low back a little angry, but you just got to kind of be supportive through it. And
Mhm.
then just know your body's going to kind of adjust and compensate as you start to stand up. And then working with a good physical therapist to strengthen your core is really essential, right?
Mhm.
That's just like kind of helping you for life. And it's helping also those muscles where we did the perforator dissection through. And I think we'll talk a little bit about that here shortly. Because a diastasis recti, although it's a bulge in the abdomen, it's something that was happening before your surgery.
Right.
And the sensation of an abdominal bulge or true hernia that you're getting from a DIEP surgery is something separate. So I just kind of want to put those two things in different boxes.
Mhm.
I'm sorry if you hear my dog, he saw the mailman. We'll see.
I can't hear him. He's
Okay.
nice and
He's
quiet.
growling a little bit.
Oh,
Okay.
okay. Well, he's doing his job. This is a
Yeah.
good time. This is a good time then to just to roll into you know, bulge and hernia and talk about that a little bit.
Yeah. So if you wouldn't mind pulling up that other
Sure.
photo that I sent over diagram, and then I can kind of
Absolutely.
explain, so the abdominal wall is comprised of the rectus muscle, like we talked about, that middle six-pack muscle,
Hmm.
and then a number of other kind of support muscles that wrap around your side. So you can see that it says EOIOTATF.
Hmm.
So those are
This chart.
all different muscles that come together. And then based on what level in the abdomen you're at, the
Hmm.
fascia or that strength layer that surrounds the muscle is starting to fuse together. And it's either going above the rectus muscle or around it. So this actually separates out where on the body these fascial layers and these muscles come together and kind of separate apart. So you can see kind of higher up, all the fascia sort of like over the muscle. They're showing you a rib there, and then sort of midway down. Midway down is where your dissection for your DIEP is really starting,
Hmm.
because most of the perforators that we're choosing are from the belly button down. So there you can see the external oblique or EO, the internal oblique, the transversus abdominis, and the transversalis fascia. And in the middle part, you see how they're kind of separated in different layers. And then once we get below this line, it's called the arcuate line, then the fascial layers from those external, internal, and transversus abdominis muscles fuse together and go over top of the rectus muscle.
Hmm.
So when we are dissecting out for a DIEP, we lift the skin and fat off of the muscle layers and we lift it from the side up and
Hmm.
we dissect out all the little perforators that are coming through the rectus. And then most of us put temporary clamps on the perforators that we don't think we're going to use. And we use a special device in the OR called a SPY. And the anesthesiologist gives you a special medication that tags your red blood cells. And then we use this device to say, oh, this entire piece of tissue can survive on this one perforator, or maybe it needs two. And I've looked at the CT scan ahead of time to know that those link up in a way where I'm not going to be taking too much muscle or nerves.
Hmm.
So then let's say it just needs one perforator. We will carefully dissect away the muscle from that perforator. And then we watch for that perforator to dunk underneath the rectus muscle. And you can actually see in these pictures, those blood vessels that are sitting underneath. It says RA, rectus abdominis, and sort of where they travel.
Hmm.
So our goal is to make a very small incision in the fascia, open it, leave the fascia intact, and leave as much muscle intact as possible. And then also, if we see any nerves cascading over our blood vessels, to preserve those.
Hmm.
Um, when you start taking nerves, the way that nerves and muscles function together is when you have an intact nerve, it's sending a signal from your spinal cord to that nerve to or to that muscle to contract, right? And contracting that muscle is what keeps a muscle healthy and strong, allows it to grow if you're exercising it, or if it's not getting a good nerve signal, it can atrophy or get smaller. So we try to preserve as many of those muscles or many of those nerves as possible to preserve strength in your abdominal core. So it's supposed to be a muscle sparing, nerve sparing procedure.
Hmm.
And then my practice, we started doing things a little bit differently. My partner, Arvin Gowda, published a paper that we'll link to this podcast
Yep.
and this YouTube about a surgical technique where when we go to dissect the actual pedicle,
Hmm.
which is, so I always think about this like it's a tree. So the pedicle means the deep inferior epigastric artery and vein. They're like the tree trunk. And
Hmm.
then that tree trunk comes up and it gives off branches and smaller branches. And then smaller branches come through the rectus muscle. And then they give even smaller branches into the fat and skin above. I think of that almost like the foliage of the tree. So we're
Hmm.
tracing that all back to the trunk. We're lifting that rectus abdominal muscle up at a certain point to do the dissection underneath it.
Hmm.
So our practice divides the midline fascia
Okay.
and leaves the transversalis fascia, that TF, down. That's covering the bowels, keeping the inside of your abdomen separate from our working space. We
Hmm.
lift the muscle up and we dissect the pedicle out from the midline. That allows us to avoid all the nerves that are wrapping around from your spine through the muscles and innervating all the muscles of your abdominal core and your rectus. It is kind of commonplace where surgeons will actually take a lateral approach to that muscle. And you can imagine if you're coming out lateral to the rectus, when you cut down, you're cutting through the fascial attachments of all of those external oblique, internal
Mm-hmm.
oblique, transversus abdominis, and also you're potentially dividing any nerves that are coming through to that rectus.
Mm.
So as much as you can avoid that, I think it's a superior outcome in terms of keeping your abdominal strength, which is what doing a DIEP is kind of all about.
Yeah.
In the past, we used to do tram surgeries or things that involved them taking the muscle too.
Right.
And we learned that that was really not optimal
Right.
for women to not have good, strong core for all the reasons that you need a good, strong core for having a bowel
Absolutely.
movement and urinating and doing pretty much anything. So we try to avoid taking any muscle, taking any nerves, and we try to do our dissection in a very thoughtful way
Mm-hmm.
to avoid disrupting fascia when we can and avoid disrupting any nerves that are growing around. And they grow from think from the spine around to the middle. Um,
Anatomically, it makes complete sense to me. And the important thing is those nerves have got to make that signal in order, for them to work in your internal system and not for things just to be lax and to fall apart from a, patient lay perspective, I guess, when I think about that.
exactly,
Yeah.
exactly.
Yeah. Okay.
So
All
I hope
right.
that kind of helps. So the reason that people get bulges, I think I mentioned this, but it could have been when I was talking to Terry before the podcast, is twofold. In part, it can be because more nerves were taken. So
Mm-hmm.
now the rectus muscle is de-innervated or doesn't have a good nerve impulse to keep it
Mm-hmm.
strong. So the
Mm-hmm.
muscle will actually slowly shrink away. And that's called atrophy. And then you can get the sensation because now you have a weak muscle
Mm-hmm.
of the intra-abdominal contents pressing out. And so when people say like a bulge is a possible complication of a DIEP, it's not a true hernia because it's just a weakness in the
Mm-hmm.
abdominal wall because that muscle has become weakened. The other thing that can happen is that some surgeons might take some fascia with it or that strength layer.
Mm-hmm.
So for a true hernia, it means that the fascia has been disrupted
Mm-hmm.
or the fascia has pulled apart in some way. So a true hernia can be repaired with like mesh, et cetera, to bolster that fascia. But really, now that there's been fellowships in microsurgery for Terry probably knows better than I do, at least a decade, right? There are more and more people who are getting high level advanced training in these specific cases. And so really like we all have to be just super excellent, right? Like the goal is for us to uh, do something in a way that we are disrupting as little muscle and as little nerve and as little fascia as possible
Mm-hmm.
so that you don't have an abdominal wall complication from this surgery.
Yeah. It's all about preserving the entire structure throughout the
Exactly.
abdominal area. Yeah. So, real quickly, I wanted to ask you because this is another question that I get, after diastasis repair, after DEEP. When, everybody has different level of activity. So, when can women return? I've had some, it runs a spectrum. I just want to get back to my daily activities, house cleaning, running the kids to the store, just going to the store themselves, whatever, to I'm a trained athlete, I'm a runner, I run marathons. Where's that window where they can begin to start thinking about getting back to an activity level?
In terms of like just normal daily activity, I think you can return to that within the first 1 to 2 weeks, really. So
Mm-hmm.
I want people to be walking around. I want them to get outside, walk around the block, just gentle, open cup of coffee, conversation with a friend kind of pace. So the two things that we want people to restrict their activity, or two reasons we want them to restrict their activity, is for the reason of wanting everything to heal and the scar tissue to be at its maximum strength and not wanting people to get a fluid collection.
Yeah.
So in terms of healing, scar tissue will never be as strong as a piece of tissue that was never cut.
Mhm.
So that scar process can get to about 80% max tissue strength, but it gets there by 6 weeks. And that's where this kind of 6 week guideline comes in, of you can go back to doing whatever you want at the 6 week mark because the scar tissue is the maximum strength. If something were to happen, it's not something that you could have prevented because your scar tissue has done its job. If it
Yeah.
was going to happen, it was going to happen.
Mhm.
Kind of in between that 2 weeks and 6 weeks is a kind of a gray area, right? The more active you are, the more fluid your body is creating. And
Mhm.
then your body tries to put that fluid into the surgical space.
Right. Healing
So
mechanism.
exactly. And it's like our bodies are not designed for modern surgery. So this healing mechanism doesn't really work with us. It kind of works against us. And we want the tissues to stick down and seal and heal together
Mhm.
instead of fluid creeping in there and trying to push the surgical space open. So I am kind of rigid about no heavy lifting greater than 10 pounds and no heavy cardiac activity until 6 weeks. But I'm okay with people like walking around, going to the grocery store, going for a walk with a friend, um, limit it to a mile at a time when you go for a walk, kind of up to that 6 week mark. And if you have drains, your drains will kind of tell you if you're doing a little too much, right? So drains will stay in a little bit longer if you're more active because they'll be putting more out. And I just don't want people to take one step forward and two steps back. So I feel like if you're someone who exercises all the time, if you can just get through the 6 weeks and take it easier than you usually do, then you're going to prevent yourself from having a complication that might make you have to go back to the OR or have something repaired, which then starts that clock over.
Yeah. Well, I want to thank you for your time because I threw in a lot of questions today from the community that I listen to every day. And so I really appreciate you answering them, showing us the slides, giving us a detailed um, description of what you do for diastasis, but also explaining the bulge and just the whole anatomy of the abdominal um, cavity. So again, I'm talking to Dr. Kelsey McClure, who practices in Phoenix, Arizona with Midwest Breast Anesthetics. We've got some links that we're going to put in the show notes, both on the YouTube channel. If you're listening to the podcast, you can pop over to the YouTube channel to take a look at the slides. There's a paper we'll put in there. We'll put in her information, how you can get in touch with her. So we did it. We finally
Yeah,
connected. We made the connection.
perfect. Now, next time at ASRM, we'll have to grab a drink.
Absolutely. I'm down for that, 100%. Listen, take care. And again, thank you for your time. And I really appreciate this information today.
Yeah, thanks for having me. All right, we'll see you soon.
All right, take care.